webinar. My name is Jeremy. I'm the CTO of Sagely Health, and I am joined today, as always, with Dr. Jason Sager. Hi, Jason.
Hello, Jeremy. Hello, everyone.
So, Jason is the founder and the CEO of Sagely Health. And today we wanted to talk with Jason about how do you help a parent with cancer. We have a number of people who come to Sagely Health and they're trying to help a mother or father deal with cancer, kind of at all different stages and different types of cancer. But we know that it's a unique challenge of kind of not just dealing with a loved one's cancer, but actually dealing with a parent's cancer. So we wanted to talk about that today. So Jason, I think the best place to start is kind of people are going through their lives and suddenly this disruption happens. Maybe it's incidental finding, but a cancer diagnosis has happened. And I'd like to just talk a little bit about kind of generational mindsets, because if we're talking about a parent with cancer, the likelihood of cancer goes up as you age. So can you talk a little bit about kind of the mindsets that people might have if they're older versus kind of mindsets we have, more modern mindsets we have today?
Yeah, no, absolutely, absolutely. And I think the first thing is, again, just to repeat what you just said, which is that when cancer diagnosis happens, then often chaos happens right afterwards, and that is within a family, but it's also between the system and the patient and their family, and so the system is one that is not necessarily there to guide, is really not there to guide sort of how families should receive this information, what should they do with this information. The system is there to assess and offer treatments, and they will tell you what that is. But that doesn't really get towards what we're now going to be talking about, which is how do patients come to grips with this, especially if they're elderly. How do the children and the family of patients come to grips with this, and how do they support each other, and how do they make sure that the best possible outcome comes out on the other side? And that's what we're all aligned to, both in terms of longevity, but also in terms of quality of life. And especially in some of our older adults, quality of life is really, really incredibly important. And yet again, the system is not going to really address those in a way that at least I feel like it should be addressed, or that we find is addressed most of the time, with some pockets that, once in a while, a patient will have a satisfying interaction with a physician, oncologist, or others, and that's awesome. But again, we want to make sure this happens for everyone. And so I just wanted to kind of start things off by kind of rehashing that. And then we can talk a little bit about sort of the generational mindsets and things that we've encountered that may or may not be a part of an individual family and their patient's sort of situation.
Yeah, I'd say that I'm glad you kind of step back a little bit, because I just want to mention, like, when the phone rings and I pick it up and I talk to someone who's dealing with a parent with cancer, the two major themes I kind of get from them are they don't know if they have the full information. They feel like maybe their parent had a meeting and they don't really understand. They really want to understand the full picture, and they feel like they're maybe missing something. And then along those lines, they feel that something's going to get missed along the lines. Either their parent's going to miss it, or they're going to miss it, or something's going to get missed. And I think that so that does kind of go a little bit to mindset, where I feel like it's almost universal that they feel like the parent is a little closed on information versus their wish to open
Yeah,
information. And I do think that comes a little bit from mindset. So yeah, any
right.
thoughts you have on
Yeah,
that?
yeah. I mean, I definitely think that there's sort of two aspects. One is that, cancer is complex and its treatment is complex.
Yeah.
And for people who are not doctors, who are, but in the prime of their working, I mean, it's difficult. And then you add into that some of the issues that happen as we get older, and it doesn't get better. It gets harder. And so some of it may have been just missing a bunch of the pieces.
Yeah.
It also, people hear the word cancer and they may snap towards a specific attitude or perception or perspective on it. And oftentimes in the older generation, what I've found with my own parents, at least, is that, cancer equals death, and therefore, or death sentence. And therefore, anyone with cancer, well, that's it. Just, get your things together, say goodbyes, but that it is a death sentence. And therefore, there's also well, if this has happened and now this is a death sentence, well, we shouldn't tell anyone about this because we'll just worry them. So we'll keep this information to ourselves. Now, again, maybe other parents are not like this, but at least mine are. And I I've seen this happen from time to time. And as much as I can do this, either for my own parents or for others, I try to dissuade them of that perspective. First of all, in today's world, yes, there are a lot of outcomes that end up with the ultimate outcome of mortality, but there are many others that don't. And again, it's also about the quality of life and how long is that and what sort of achievements can be made towards specific goals, specific events. For example, I really want to see my granddaughter or grandson graduate from high school, from college, attend that wedding in a couple of months. Is that achievable? Will I be able to dance at that wedding? Right? Those are questions that we've been asked. And the answer is almost entirely yes. There is a way to get there. Sometimes it's no, but most of the time it's yes. And so let's work together to figure out sort of how to optimize that path between where we are now is current reality and really where the person really finds value in getting their life to. It may be going on a cruise and enjoying themselves, going to a vacation home that they have or one that they rent and enjoying themselves. There could be a bunch of different things. And we'll talk a little bit more about some specifics as we go through this webinar today.
So when you talk about having those goals, what are you balancing to try and achieve those goals? Like, is it kind of taking on treatment that could lead to side effects, of understanding kind of a maintenance of your cancer versus going for a cure? I just kind of, because I think that's really interesting. And I think that when people kind of understand that, I want to know what's kind of making that possible, that may have had a mindset where that wasn't possible in the
Right.
past.
Right. And so, and I think it's individualized. And yet what we can say is that, that the way that cancer treatments first started and are largely conducted today is with this mindset that, hey, we're going to hit this thing really, really hard. We're going to try to whack that cancer as hard as possible, such that it might shrink, it might, stay stable at that low position for a long time, but usually at the cost of making the patient feel not so well. And sometimes with the traditional chemotherapies, it can be quite sick. With newer targeted therapy or immunotherapy, the hope is it's better. But there is that sort of perspective of the standard way to go about it is, whack it hard at the cost of the patient's well-being. And if you're 24, and you have a full life in front of you and many, many years, and you feel robust, although there's some 85-year-olds who also feel really, really robust and they can tolerate these things. And then there's some individual variation, so you can give it a try. But more and more, not having the perspective that there's a way into this that allows optionality. I'll give you just one example is, a patient came to us and said, well, you know, this is a high risk cancer. We'll talk a little bit more about that. It's spread throughout the peritoneal cavity. So now it's not a specific place, it's sort of throughout, and radiation can't touch this, and maybe there's some injections that can do this, but what do we do in this situation? And we just want to get, to enjoy life, want to travel a little bit, want to see some family, some months, but not feeling sick. Is there anything that can be done? And again, the answer is almost always yes. One of the ideas is, hey, you can take those medicines that are used, the chemotherapies that are used, even the traditional ones, but they're usually used at really high doses and wax the patient. Well, try a little less. Start with what I call a baby dose or a mini dose of the same cancer agent, especially if it's an oral one, that then could be ratcheted up as time goes on. See how well does the patient receive this? How, are they one of those that they're like, hey, I feel great, on the chemo and doing fine, versus one who they take a whiff of this and they're like, oh no, can't do that. Right. And again, so enabling options with one of them being start low and then incrementally increase as tolerable, or start low and then see, does it stop the cancer from growing? Again, the goal is not always to shrink the tumor, but really just to stop it from growing such that life can continue unabated. And so, and live with cancer, basically indefinitely or until, long time from now. And so those are some perspectives that don't usually get communicated by the system, but I find it really helpful to have in mind and ask the doctor about proactively, the oncologist.
Yeah, I think I just want to point out that when a lot of people end up with a doctor and the doctor will make the recommendation the system is kind of pushing to be made. And I think you do have to be proactive to create a pause there. And the oncologist may not be the right oncologist for you to kind of have that optionality. So it's often taking kind of a view of the doctor where it's like, well, there's an option I've been given. Is there any other options? And unfortunately, it may not be with that doctor. That
Right.
doctor may say, this is the option I have. So I want to get to risk in a second. Could you talk a little bit about kind of like how kind of the
Yeah, yeah,
the older generation kind of views the
yeah,
doctor,
yeah,
and it
yeah.
might make it
Yeah, yeah,
harder to
yeah. Well,
kind
yeah,
of do
I think that's a perfect thing. And again, let's give everyone the secret sauce that oncologists use. There's a manual. It's a PDF now electronically, but from the NCCN, the National Comprehensive Cancer Consortium and network, and then and they put together the recommendations for this therapy. And again, remember when we talked about the sort of the whack it hard? Well,
it.
that's where it's documented. So when the oncologist, any oncologist, all oncologists take a look at this, that's what they're going to see. This is the treatment. This is the diagnosis. You got metastatic colorectal cancer. Okay, first line, second line, third line. These are the treatments. Here are the doses. Here's the frequency. What they don't talk about is some of that perspective, the alternative perspective, because it would become too complex. Some of the doctors will automatically, ask about this and sort of latch into that. Some of them won't, and that's where this all comes from. And again, so therefore, as you mentioned, it may be that one doctor says, no, we've got to just, this is the standard approach, this is what I've got to do, and not really being adjusting for the person who's in front of them. Another doctor may say, yeah, that's the standard approach, but we can make some adjustments and maybe get to it a different way that makes it a bit kinder or more easily tolerated in the beginning. The downside is it may not work as well. But if you understand that, and again, the goal isn't to try to get that tumor to disappear because it's all over the place. So the likelihood of that's really low. Instead, we've got a kinder approach, a gentler approach that allows patients to kind of get into it and then perhaps stabilize things, feeling good, being able to live their life, and yet with stable long-term stability. And there's that the name for that is called metronomic dosing. So if you're watching this and you're in the situation, you can ask the doctor for metronomic dosing. I do want to get to the point though that it really does take another concept now to sort of have that in mind that, hey, like, well, what if one doctor says, whack it hard, like, another doctor says, well, gentler, like, is there a right and a wrong? And again, this is what we do to guide patients at Sagely Health. We listen to them, we assess what are their goals, what do they want as their outcome, and then we help them to find that and navigate the system in a way that gets there. For the doctor who says it's got to be this way and it's whack it hard, say, hey, doc, how about this metronomic dosing? I've heard that this can be gentler and perhaps get us some months of stability, which is really what we're looking for here. On the other side, the one who starts gentler, that's great. But maybe after a couple of months, you're like, hey, like, could we go a little harder, doc? Or maybe it's even like, hey, we tried that gentler thing, not working so well. What else we got? And go back again. And so really it's about the idea that it's an interaction, it's a relationship, but it's also with more than one doctor. And this is an important point because, again, generationally, the old idea was you have an illness, you go see a doctor, that doctor provides treatment, and then you're done. And if you have an infection and the treatment's antibiotics, then that should work. Now, once in a while, it doesn't work. And then what do? You see a specialist, right, who may know something more specifically about that infection. Here, the same thing holds true, except for the fact that for high risk cancer, all of us doctors don't have the answer. And therefore, putting our heads together from the beginning is the best way forward. And as such, you really need a team of doctors that can be accessed at a single center as a tumor board review. something that every patient with high risk disease can and should ask for at their hospital. But it also can be from multiple institutions. And I think that that is when things work best, is to have a team of doctors, probably three or four, who are really helping, and talking to each other on a regular basis, maybe are looking or are fed sort of what innovative treatments and options are out there, and then putting their heads together to create a strategy, a path that really offers multiple options over time, that is geared to start with the gentlest, if that's the goal, and then to work your way up, or to start with the one that's going to have the best outcome and then go from there. And again, aligning with the goals of the patient and the family.
So I just want to go back to risk for a second because I think it's worth bringing out because you're talking about what you should do if you're high risk. And I think there's often a not understanding of the risk level. So can you talk a little bit about how you think about risk and how kind of that helps kind of gauge how proactive
Yeah,
you should be and how you should act kind of
yeah,
within the
yeah, yeah.
system?
Um, and so yes, from my perspective, high risk disease or high risk cancer is any cancer where a cure is less likely than a low risk cancer. And we set the bar at 80%, so we have a pretty high bar of expecting that, if you're not going to be cured 80% or more of the time, we would call that high risk. Some patients may say 50-50. But regardless, we know that a lot of cancer falls into the high risk category. Those are things like metastatic disease. Not all metastatic disease, but most of them are in that high risk category. It could be other things as well, with a large tumor versus a small tumor, things that are in a place that are inoperable or what we call borderline. And so there's a number of different situations that bring you into that high risk category. And again, we help patients to understand this all the time. Low risk doesn't mean that there's not a need to do these sorts of things. But again, what you may do is a bit different. If you have time, and low risk disease, generally there's more time to think about, to get information and align on options, and make decisions. Those are sort of the three steps. Um, but still, and I was just guiding a patient this morning and their family, where it's low risk, and yet, they went and talked. They were sent to the surgeon, and the surgeon says, "Yeah, we'll operate and take that out." Well, this woman is 89 years old and is asking the question, is there something that would allow me not to have to go to surgery? This was a lung tumor. And again, one that there was actually two, one on each side, one that looked benign but growing. So that could still cause problems. One that's malignant, but barely malignant. So it wouldn't spread very fast. But the surgeon is like, well, let's start with the malignant one and take out one of your lobes of your lung. To which she's like, okay, but what if the other one needs to be taken out eventually? Like, how much lung am I going to have left? I don't want oxygen. I don't need oxygen right now. Are there options? And so optimizing this either way, I think, is a really useful paradigm to look at, and really being proactive, saying, hey, doc, that's great. Whether it's a surgeon or anyone else, I'm going to get a few other opinions, come back. I would like to talk to a radiation oncologist. I'd like to talk to a medical oncologist. Could you set me up with that? Could you help me to reach those folks? And then coming back to the table. And again, we help folks to do this all the time. And so we see the benefits of having done it, and then coming out with a strategy that really makes sense for the patient.
So just to summarize really quickly what we've talked about so far, in the sense that when a diagnosis happens with a parent, the best thing you can kind of do is kind of say, can we put a pause and really gather information? Because we need to. How high risk is this? Because you might be dealing with a cancer that has a 90% chance of a full cure. And do you understand that? Is that clear? And if that's not the case, if it's a high risk, then you've got a chance to kind of pause and say, well, what are our options? What are the pros and cons of those options? What are our goals?
Yeah.
Knowing the risks very clearly. And I think when families, I've seen when families kind of have like kind of open eyes with kind of how high the risk is and kind of what they're doing and why they're doing it, which is
Mm-hmm.
kind of like, sometimes the family members don't all agree that we're not going for a cure right now. we're just going for, like you said, like a metronomic dosing to give a good
Yeah.
quality of life over a period of time. And so just getting everyone on the same page of kind of understanding the information. And I think I just kind of want to say that's like kind of the beginning, right? That's kind of, so I'd like to talk a little bit about kind of what are the things that you can do to help kind of with those being your goals.
Yeah, yeah.
Like,
Let's talk.
what
Yeah,
should
let's talk about that because I think it's a critical point. Before we do that, I want to just address the one aspect of pause, where sometimes a pause or not even a pause, because we're going to, oh, okay, great, schedule the surgery, great, it'll be in a month and a half. Okay, that sounds fine.
yeah,
There's a
okay.
lot of work we could do between now and that month and a half. Okay, great. And that's in this case what we did. Um, on the other hand, sometimes they say, well, treatment's got to start right away and we can't wait. And you may have a friend in the family who's a doctor who you could ask, come to us, we'll tell you, is that true or not? There's never a problem with starting off on the path that is presented in front of you, knowing that again, doses can be lowered, things can be spaced out, breaks can be taken. But if it's really urgent and the doctor really believes so, and you've maybe gotten some quick validation that that's the case, it's okay to get started on something and then still do this process of
Yeah.
information gathering and option generating and decision making. And so those are just some quickies. But I do think the point that you brought up is one that we should talk a little bit about, which is that involvement of the family in understanding the situation and that sort of shared decision making, or at least getting opinions from those who really would feel left out if they weren't participating, right? And it doesn't necessarily mean young kids and that sort of thing, but you know, who's close to this individual, and they may not all be speakers. They, if you have a college age student who is really close to grandma, you may want them in the room. They might feel tremendous loss if they weren't involved in the process. On the other hand, brothers, sisters, sons, daughters, all of these folks can matter. And not only can they matter, but they can also be quite helpful because there are various roles. And, sometimes it's just, hey, aunt or sister of the patient, could you be the note taker and go to the doctor's visits? Or even just, uncle, could you drive your sibling to the doctor and just make sure that they're delivered and come home and that sort of thing. Those can be enormously important things. They are enormously important things. And so helping to understand it, and again, it kind of goes against that initial like, well, we're not going to tell anyone, we're just going to keep this to ourselves and deal
Yeah.
with this on our own. Again, in general, there may be some specifics for reasons to do this, but in general, I try to help folks to get into a network and access that network. Could include neighbors, friends, could include religious organization and groups that they've been close with, ministers, pastors, rabbi, whoever, people who, again, have been included in their life who could help. And even if it's just moral support, not incessantly, but certainly a few individuals can really be important to involve.
Yeah, and I think you've talked a little bit about handling some of those logistics, and I think one of the important things is kind of somebody helping people understand how they can help. I see that a lot of times. They're saying like, okay, I'm going to assign you. Can you drive? You can drive. Okay, then you're going to take them to the appointments. Can you
Right.
take the notes? And like that's what we're asking of you. You know now how kind of how you're contributing, and it's really important and that sort of thing. And then so then I also want to ask about kind of what should you do on the this is also confusing and complex when you start to get into the information. Like, how should someone kind of look at research as like trying to help their
Yeah.
parent? Because I think that's probably people I see the most overwhelmed. They're kind of like, I don't understand what I'm reading. I'm seeing stuff
Yeah.
online. I think this is what it is. Like, and so what do you recommend in that
Yeah.
case for people?
Yeah.
Yeah.
It's tough. And again, have that perspective of, I want more information. I want more information from the doctors in front of me. I want more information from a team of doctors. Maybe it's one at the medical center through the tumor board. Maybe it's a few other doctors who are experts in their field in this area. Again, it's important for a NCI accredited cancer center, I think, to be on the list if that's possible. And there's public listings of those, certainly we help patients to figure out where to go and who to see to get the most information. Um, and then come back together and discuss that. And so to me, those are some of the keys in those initial steps. Obviously, having a doctor on your side, someone in the family, they don't have to be an oncologist, but someone who's gone through the medical training and understands medical information, I think can be also really helpful in digesting this. It could be a friend, it could be a relative, distant, close, whatever. Those are folks that can be really helpful. And as I said, we do this for people too, in the sense that we fill that role of sort of interpreting and understanding and guiding in terms of what could be a next good step.
I want to go back and ask about a couple things related to age, and do people get offered different treatments? I mean, we've talked about kind of selecting, asking about metronomic dosing and those sorts of things that change, but are you really offered different treatments when you're older than
Yeah.
you would be if you're younger?
Yeah, it's a great question, and the answer is it depends a bit on the cancer type and the situation. Remember that NCCN
Right.
once in a while, is given a specific cancer, and usually the ones that occur in elderly, but they will say, okay, well, for an elderly or frail patient, they get this treatment, but in a younger person or someone who's robust and or both, you'll get this treatment. And again, like some of the examples or one of the examples that come to mind is, let's say for pancreatic cancer, fulfurinox, right, which is like four different agents all stuck together in one word. That's for folks that are more robust. Or in leukemia, you'll see a bone marrow transplant being offered to someone who's got robust and they're not in the elderly, which sometimes is defined as over 65, um, not in the frail sort of categories. And again, they're not always the same. So having some personalized attention to that and making wiggle room decisions, I think is a good thing to have. But when you look at the list, I mean, they try to, it's complex. They're trying to simplify it, so they kind of divide into those two buckets. So sometimes that exists, and sometimes it doesn't, and then it's just sort of a one size fits all. And so finding out what those options are and how you're being treated and how it's being individualized, I think are important questions for the doctors.
Yeah, and I think if it hasn't come across. I mean, the thing to do is to ask a lot of questions, and once you get into that appointment, have your list of questions ready to go. Be preparing that kind of understand somebody has that list. They're going to record the answers because you sit there and you ask a question. You actually have a pencil ready to like
Right,
record what the
right,
oncologist
right,
says, and that does make the oncologist kind of pause and say, this is not something off the cuff. I'm going to think
right.
about what I'm
Right.
responding
And
here.
what's
So
even better is let it be anti, so that patient, and children are all in the room or on Zoom or on the phone. And we should talk about what happens when, children are far from their parents. But, that there's basically people listening to digest the information that's being presented to them and coming up with the next questions versus recording what those answers are. And again, a tape recorder works well also. So, do you mind, Doc, if I just record this so that we can listen to it later and kind of redigest things as we've heard it, because we may not catch everything.
yeah, that's a good thing you brought up the idea of helping from a distance because we definitely run into that where children have moved away from their parents and so they're helping from a distance. And so, any recommendations on kind of how to navigate that?
Yeah, I think it goes back to the network and really trying to assign roles and then just doing what you can do, as much as you can do. But to be proactive in a way that does work for you and for the patient and the family. And so again, those group, and the way we do it is, and I was going to mention this before, when we have these sessions, we will have a Zoom meeting where we'll have everyone who's in the family who wants to participate and the family's comfortable participating. They'll all come into the Zoom. We talk about what the objectives are for the next step. We actually, as we talk, we come up with the questions. We've got people to record those questions and send it to the patient and the family afterwards so that they can print it out when they're in the doctor's office. They can go through them. Sometimes, obviously, things come up and they navigate away from that, and that's okay. But in general, they're left with a structure that makes everyone feel like they have a role, they have a part to play in this, such that they can express their love for that individual in a way of action and in a way of caring. And that's really important. And at the same time, we get really helpful information out of it. So that's sort of a general structure. That being said, I think, having those roles assigned and doing, and being creative about getting it done. So if you're a daughter or a son and you're far away from your parent, maybe there's a younger, if they're, technologically savvy person in the family, whether they're old or young, but they can go and be with the patient as either the note taker or just the listener, but to make sure that, hey, doc, can we, patch through, can we conference call with, son and daughter so that they can participate in this and at least listen? Sure. Okay, great. Let me give them a call. Let's all set this up. And so just having that part of it is a really good thing to do, so that you can participate from afar. And and again, I'm sure people will visit, and there's never a bad time to visit, even if it turns out to be unnecessary. Go and visit and help. Whenever possible, participate is really nice. Some families can, some families less. And again, at the end of the day, what really matters is trying to help that patient to achieve what they would like, and collectively what you would all like to do for them.
Yeah, I want to touch on one thing that can kind of get in the way of that goal, which is, we talked about kind of open information, collaboration, kind of communication, kind of being very clear eyed about things, talking about risk, understanding prognosis, talking about options. And the thing that can kind of get in the way of that happening is the mental strain. Of cancer and the mental health issues that can kind of arise. They can pre-exist before the cancer, but it's such a large load to carry for the family members and for the person. So I want us to ask you a little bit about kind of how do you keep an eye on the mental health of the person who has cancer, but also the caretakers around them and
Yeah.
yourself if you are that caretaker.
Yeah. No, it's incredibly important. And I think the word here that comes up for me is compassion. Compassion for each other, compassion for yourself, forgiveness for each other, forgiveness for yourself, grace. This is really tough. And it's the sort of thing that, again, no one chooses. No one, says, "Oh, I'll get cancer now." So again, it happens. And when it does, having, organizing so that you can assess sort of, okay, my job is really demanding. It was really demanding before, and now I have a sick parent or a parent with cancer, and that's stressful. It's frustrating. My job is going to, be even more stressful than it was before, and it was already a high stress job situation. And that's important, to recognize and then to plan with, right? So, are you comfortable telling your work or taking a medical leave of absence or a family leave of absence for yourself if you have cancer or your loved ones? Again, asking, for guidance about about what can be done with employers, what's appropriate for them to ask, especially if you're in the US. There are a lot of rules set up around what employers are allowed or not allowed to ask. And again, just knowing what your options are so that you can put them to work for you. But then also, making sure you're nutritionalizing, making sure the patient is getting enough nutrition and keeping active as much as possible. Same thing for the family members. Again, I've seen many times where the patient has got cancer, but actually something really unfortunate happens to a family member because they were shocked, they weren't prepared, they were stressing themselves out, they were not eating, they were not sleeping, and all of the whatnot. And so at the end of the day, it's really about the collective health of the family that I think is most important. And obviously everything is going to be focused in on the patient, but it's also important that the caretakers take care of themselves and each other.
Absolutely. So my last kind of question for you, Jason, is, I know that you have parents who have faced cancer diagnosis
Yeah.
and you happen to find yourself in a high stress job and you also have a great deal of expertise in this area. So I think it'd be helpful kind of like, what did you do that you think
Yeah.
maybe the average person wouldn't have done to kind of address your parents, help them navigate, their
Yeah.
care?
Yeah. And when I was giving the prior answer, it was the picture of my parents that were in my head, right? So it's just like, and just to dive into it, I mean, there was a point when I was, I think, sleeping next to my dad, I think on the floor, maybe on a mattress that I had stuck on the floor, maybe I'd taken out of a different hospital room to put on the floor. And, I was kindly invited to go get a hotel, told where the hotel was right down the street, told that, hey, if anything happens to your dad, we'll call you. But like, you're not well, Dr. Sager. Like you're showing us that you are at levels of stress that we're worried about. And
Right.
so feel free to take us up on this. We won't pay for your hotel room, but pretty sure you could probably afford it. So like, let us help you to do this. And I was just like, oh wow, like, well, like, oh my, like, didn't have awareness of that. Was totally focused on dad 24/7, and sort of fell into this trap, this sort of pattern that is not uncommon. And so it really is about that. But let's rewind and just talk a little bit about, because I have two parents, both of whom had been diagnosed with cancer, who I approached somewhat similarly, which is, again, step one, get more information. Even as an expert, again, knowing what I know, I'm not an expert of chronic lymphocytic leukemia, which is what my dad ended up having. I'm not an expert of locally advanced basal cell carcinoma, which is what my mom ended up having. But I know how to get more information. And so for my mom, she was in New Jersey, we got her to Memorial Sloan Kettering, an NCI accredited cancer center. We saw Dr. Arian, who is a wonderful surgeon, who said, yeah, I can operate on that lymph node and take that lymph node out, and your mom will have no evidence of disease. But we know that it's a high risk cancer. The likelihood of its coming back is quite high. Now, maybe in a couple of years, but still, your mom wants to live for 20 or 30 more years. So, should we just do that? Well, Dr. Sager, you brought to me this information about immunotherapy that you found by talking to other doctors. Go get that. Go try that. In 3 months and 6 months and a year, I can come back and do the same exact surgery with the same exact outcome. So if it starts to grow, yeah, come back and we'll take it out. But maybe there's a chance that it'll not grow. Maybe there's a chance that it'll even shrink with this immunotherapy. Worth taking a look at. That's awesome, right? That was really life changing for us because then it allowed those other options. At the end of the day, we went down to Johns Hopkins, not so close to New Jersey, but it was once a month, and they made the trip and they were dedicated to this and they really wanted it because of that high risk. They understood that and they were going to try this immunotherapy. And Dr. Lipson at the Hopkins Hospital was offering that in a clinical trial. She got on it, did well, didn't have too many side effects. But at the end of the day, the tumor wasn't shrinking, it wasn't growing, it was just kind of sitting there. And when COVID came along, decided now is the time for surgery, had it out, and knock on wood, multiple years later, no evidence of disease. And so we won't use the C word, the cure word yet, but that's where we're pointed. And so that was to me a really, really helpful sort of pathway forward. And then let me ask if there's any questions that you have on that, and then we'll talk about my dad's situation.
No, I mean, I think I just underline that, like, it's information. It's you finding and bringing information into the process. So it sounds like there would have been a different path without the immunotherapy, but you inserted the information about immunotherapy being a good option because of a higher risk for recurrence, and then you're identifying of a clinical trial and understanding that it was worth the effort, right? Like you said, it was a travel, but I think you could have clearly explained to your mom, to your parents, to your family that this is worth doing. Here's
Mm-hmm.
why. And so I think just to say that it's that information, it's creating those options from having information and then being able to weigh them, which is, I think it's actually one of the hardest parts, because I think you can kind of go out there and you can say maybe there are other treatment options, but is it really worth it? Are we really going to give it a different
Yep.
outcome? And it's that information, that expertise, which I think helps guide that decision. So I just
Yeah.
say that that's what I kind of take away from your mom's story, which
Yeah.
is that you kind of were able to insert more into
Yep.
what this is.
And I just want to make the point. I wasn't alone in doing this. We
Yeah.
weren't alone in doing this. So my sister Jessica, she was on all of these teleconferences and Zooms where I was discussing with them. Here are the options. Is this really worth it? There was a point where my dad, who used to drive my mom down to Hopkins, he got sick with, I don't know, the flu, pneumonia, something, right? And he couldn't drive her. And then, their neighbor, who they've been friends with for a really long time, stepped in and said, "Yeah, I'll drive you. I'm taking you down to Hopkins this time." And Barbara's great, and it was like a lifesaver, right? We had another friend of the family who is actually a medical, like an EMT person, stopping in to make sure, how's my mom doing physically? Does she need physical therapy? Are there things that she could see that might be dangers in the house as my mom goes through this? That, yeah, just to help. And so it's really, again, about that network effect and bringing them together in a way that can be really helpful without it being like everyone, but a few individuals who really can step in. And it's not like we were particularly close to this other person that I was mentioning, the MT person, but we recognized that she had a unique sort of mindset that could come in, and she was happy to do it. And so,
Yeah.
great.
Yeah, I mean, I think that, like you said, it takes a network of people and it takes persistence. I mean, and that's what I've seen with patients who have really done well in the system is it takes a lot of persistence. So I think that having motivation, I mean, obviously we have the motivation of keeping our loved one with us and a good quality of life for as long as possible, but it's also that motivation of like there's really a great chance here, this is worth doing. And I think that's the other thing is what I see when we offer things to Sagely Health, we're kind of able to come to them and say, here's something you can do and here's why you would do it and here's the data that
Right.
exists. And so people can kind of make these really informed decisions so that their persistence doesn't go to waste, it actually
Right.
feels really productive,
Right.
like.
Right.
So
And
anyway,
and don't be shy about it. The system is not there to enable this. The system
yeah.
is there to provide a diagnosis and provide a treatment, and really to optimize on like minimizing everything else. So just because the doctor or maybe their nurse or coordinator, as this morning we just heard about, tells the family like, "Oh, no, 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 you don't need a referral. We're not giving you a referral to see a doctor. No, no, no. You just need the surgery. Just get it done. Like, what do you want me to cancel the surgery? Is that what you want?" And again, it's like I'm being threatened. Should I
Right.
think less about the doctor for this? Actually, no, you shouldn't think less about the doctor. It's unfortunate that these things happen, but that's the system. It's the system. But at the same time, don't say yes, don't give into it. Say, okay, well, no, 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 we want that date. Just keep that surgical date in a month and a half. Thank you very much. And then bye. Oh, insurance company, do I need a referral? No? Okay, great. I'm going to go see that doctor and that doctor and that doctor, and then we'll decide about the surgery. We don't have to tell us, the coordinator about that. We don't have to rub them the wrong way on purpose. But it's not easy. And you're kind of like, why? We just got cancer. We're in chaos. Families all fighting with each other. Crazy things are happening. And now I've got someone threatening to take away the surgery. Doesn't make a lot of sense. And I would agree with that. But it happens all the time.
Yeah. No, I mean, I see it firsthand all the time. I mean, it's just the system will kind of push you somewhere, and and a lot of times the doctors are very open. They're just actually kind of hard to get to. They're hard to kind of have the attention of them, and I think you have to be incredibly proactive. And I
Right.
think I think it's the information that there are other options out there that can help people be proactive. So I think. But anyway, with the time we have left, I'd love to just get to hear a little bit of your
Yeah, yeah, yeah.
backstory,
So
your
with
side.
that, he had CLL, he had pre-CLL, so we kind of knew that this was coming for quite some time. At the time, and maybe even today, the expectation is no one gets cured with this, and so wait until the very last minute before you start treatment. That's something I'm hoping is going to change in the near future, because when you wait for the very last minute and you start therapy that works, then actually the patient can get quite sick from just the initial therapy, and the fact that not that the therapy is causing a problem, but the cancer just melting away as this chronic lymphocytic leukemia did, can actually cause lots of medical problems. And I'll go through a little bit, but my dad was being followed at Memorial Sloan Kettering, obviously an NCI accredited cancer center. So we were like, yay. But at the end of the day, when it came down to treatment, and I looked at what clinical trials were available, and he was in New Jersey, Robert Wood Johnson turned out to have a trial that fit him perfectly. And it was a mixture of three medicines that had never been used before. All had been used individually, but never had been used before all together in a sort of this way that the trial was trying out. You try this medicine first, you come in with this medicine, you do it. Okay, great. So said, with all due respect, doctor at Memorial Sloan Kettering, we're going to go over to Rutgers and go get this clinical trial. To which the doctor was like, huh, well, like took it like a personal insult. I was like, no, don't do that. It's not personal insult. I love you, doctor, but we got to go get the trial. Like, it's not about choosing the best doctor; it's about choosing the right treatment. So we went over to Robert Johnson, also a great doctor over there, Dr. Banerjee, and we got on the trial. And again, these medicines work well. They work so well. And Dad was so far along, further along than I think. He was so tough, and he was kind of compensating without really letting us know. And then when he started to not compensate or decompensate, it was not good, right? So he needed 4, taps to his lungs because it had found a way around the lungs. And he it was tough, and that's where I ended up sleeping on the floor and going 24/7 with him, and I was going to make sure that he was going to live and get through this. And again, it worked, right, with the staff, with the wonderful doctors, and everyone else around, who, again, Rutgers is great, Memorial Sloan Kettering is great, they're all great, but we came out on the other side of it. But we came out on the other side, and he's got no evidence of disease. This magical combination of these drugs, a BTK inhibitor, used to be ibrutinib. Now I think there's I think zanzabrutinib, the venetoclax and obinutuzumab. Those are all really big words, but put together in the right way, most of the individuals on that trial have no residual disease that can be detected on a bone marrow aspiration. And so he's gotten looked at the bone marrow. They don't see anything. It's been years since that has happened. He's been off of all therapy, and he's living his life, and he's loving things. And so, again, a win that wasn't so easy to get to, but with effort and attention, we're able to get to the place where now he's having a great life, and it's really awesome.
That's great. Let me ask you about that triplet that he was given. Is that now an approved indication
Right.
for CLL?
One would think it should be, right?
Right.
And yet it's not. And the reason is because, unfortunately, COVID happened at the same time this trial was going on. And COVID, unfortunately, killed some number of individuals in the trial, equally on both arms, because COVID didn't care. And so at the end of the day, when they looked at what is principally the outcome of this, which is survival, they see no difference, because COVID killed just as many people on both arms. But again, 24 out of the 26 individuals on one side had no evidence of disease on a bone marrow, and lots of people on the other side did. And so, it's pretty obvious to me, but when the FDA looks at this, they're looking at survival. The good news is that there's a new trial going on right now with, again, a substitute for one of the drugs, but basically the same 3 classes of drugs,
Right.
that I am hopeful, and I think the world is expectant, that will come out with a very positive, and maybe with acalabrutinib, but a very positive outcome. And so, and then it would be standard. And so my hope is that we'll get there. We will get there eventually. But it's really cool that we were able to get my dad the future of cancer cures. And again, I'll say it there. Right now, we call them no evidence of disease, but the future today, right? Or even yesterday, right? And that's where that's what we do for patients day in and day out.
Yeah, one of the reasons to look to clinical trials or even accessible treatments that are kind of innovative in how they're being used is that, not everything leads to an approval. But there's tons of patients that will benefit in the steps leading up to kind of the trial going through. And so this is a case where there's a scientific basis. You saw it, you got him on the trial, great outcome for him. And the world might be delayed to give others that same outcome. So yeah, it's a good lesson of why being proactive and having more information is just so
Yes.
valuable.
Yes. Yeah. So if we were to summarize, I think, from my perspective, it's about that sort of, take a moment, right? Whether it's a pause or a delay or just a start now, or a, hey, sure, we'll take that surgical appointment in a month and a half, and then do some research, do some, some information gathering, talk to people who are experts, talk to individuals in the family, set up a team within the family, people who are going to be note takers, people who are going to be helpers, people are going to cook food for you, people are going to drive. Be there for each other, allow each other, share. Don't keep this to yourself. And then, gather information, put together from that options that enable the best decisions to be made in a shared decision manner that seeks patients to get the longevity that they're looking for, as well as the balance with the quality of life that they're looking for. And again, we're here to talk about parents, but really this applies to anyone at any age. You know. And so at the end of the day, looking into innovations that are out there, and and again, it's most important when it's high risk cancer, but it's not doesn't mean that it stops at high risk cancer. And so there are options there with clinical trials and radiation and metronomic chemotherapy and other targeted therapies that can really help and leave patients with that quality of life, even if there's a risk. And so assess that and together make some decisions, put them into place, prioritize, start, knocking off the options and seeing what works in a way that's most gentle and gets the patient really what they're looking for. And that's sort of the summary. There's a lot to that. And that's why we're here to help guide every step of that way.
Yeah, I think that's a great place to wrap it up. So yeah, I'll just say it's sagelyhealth.com. If we can be of help, please do reach out. Thank you so much for the time today, Jason, and thanks for sharing your story. It's been
Yeah.
wonderful.
Thanks, Jeremy. Thanks, everyone, for joining. And I look forward to speaking to you soon.